Good morning,
Hi.
Dr. Sayan. How are you doing?
Good morning. Hi. How are you?
Yes, I'm doing fine. We are
Yes.
grateful for Dr. Sayan to kindly agreeing to take
Yeah.
this
No
call.
problem.
So, Dr. Sayan has been one of my mentors when I was preparing for my FRCR exam, and he has completed his medical training and radiology residency in India. He has been a recipient of a gold medal during his medical school. He has also done oncology imaging and intervention fellowship from prestigious Tata Medical Center, and he has extensive experience in oncology imaging. And he is here now, working as a consultant in thoracic radiology in Nottingham University Hospital, and he enjoys traveling in his free time and reading. And we are grateful, Dr. Sayan, for agreeing to take Viva, and nice to have you here.
Yeah. Yeah. No problem.
And if you don't know, like, he also has written a detailed thing on Radiogram about a practical approach to FRCR. It's a good read. You guys can go through it later on. Yeah, and it's okay.
Yeah. Thank you,
We,
Akshay, for introduction.
I
I
think
know Akshay for quite a while now.
I will just
Yes.
mute myself, and then I will. I think we'll start with the
Yes.
candidate.
Okay.
Shall I start?
Yes, you can start.
So this is a 45-year-old male presenting with abdominal pain and diarrhea for 3 weeks and has a past history of inflammatory arthritis.
Yeah, that's right. You can press 2 now. Yeah. Okay.
So I have been provided with frontal radiograph of abdomen in a supine posture for a skeletally mature patient, wherein I can see loss of hostrations in the transverse colon and with mild wall thickening, giving the appearance of lead pipe. However, it is not grossly dilated. I'm still actively looking for any other lesion in the abdomen. Wherein I can see lead pipe appearance of the descending colon too. There is no evidence of free gas or portal venous air, no abnormal soft tissue calcification. I'm not sure about the bilateral sacroiliac joint sclerosis. To me, now it looks fine. Bilateral hip joints appears normal. In my routine practice, I like to compare this for the previous imaging because the patient has got a history of inflammatory arthritis. And for the appearance, my top differentials are of inflammatory bowel disease, and I'm trying to correlate if inflammatory arthritis related other diseases could be possible. So the
Okay.
leg
So,
pipe.
okay, fine. Yeah. So you're doing well. So I just wanted to know, like, you talked to me about the sacroiliac joints. So do you think they're okay?
I'm not sure. For the left side, I'm definite that there is gonna be a fusion there, but on the right side, due to overlying bowel gas, I'm not certain.
Yes.
So
Okay.
too early to comment. But
Okay.
definitely, I'll raise the suspicion for sacroiliitis.
Great. So, since your first diagnosis is IBD, isn't it?
Yes,
Yeah. So, which subtype of IBD are you thinking about?
ulcerative colitis.
Okay. And what will be your next investigations, or what will you suggest to the clinician?
Along with the serum calprotectin and other inflammatory markers, I like to have an cross-sectional imaging for the patient, depending on the practice in that particular institute. But I would
Okay.
suggest for an MR bowel, basically.
Okay. And just to take it further, so what are the findings that you will tend to look for if you do an MRI of the small bowel?
So again, there would be this loss of hostile markings in ulcerative colitis, but it totally depends wherein we see the distribution of the findings. Like I have to see for whether it has involved the rectum or not, which part
Yes.
of the colon. if it is the entire colon involved, then it is definitely ulcerative, and a component of backwash ileitis has also to be looked for. And then I would also be looking for an extraintestinal manifestation which are associated with ulcerative colitis, like primary sclerosing cholangitis. Most common ones are the presence of gallstones to look for.
And what is the fine, that's good. So what is the closest differential of ulcerative colitis?
Crohn's disease?
So in case of Crohn's disease, what are the things that you are supposed you will look for if you do an MRI of the small bowel?
So it would be a skip lesion, which I have to look for basically in Crohn's disease. And most common involvement in Crohn's disease is of small bowel. And then the colonic...
That's fine, because I want to show you more cases. Anything in particular that you will look for in Crohn's disease regarding to the small bowel?
The ulcers.
Other than ulcers, anything?
And
okay, fine. I think you did well. So
next case is of a 30-year-old male presenting with fall with head strike, and the GCS is quite low of 5.
Yes. Now go to 2. Yeah, that's right. Yeah, you can. I think you have the scrolling option as well if you want to scroll.
Yes, I can.
Okay.
So yeah, I'm trying to. Okay, I can scroll it through my mouse. So I'm trying to go from top to bottom on a plain CT head, axial cuts in brain window, where I can see evidence of extraaxial collection lenticular shape centered in the right temporoparietal lobe, with swirl sign within and small air focus on its medial part. And I can see a hypodensity on its superior aspect. It has caused mass effect on the ipsilateral gyri sulci, and with the midline shift to left. I cannot definitely see any component of subfalcine herniation, or I try to look for uncal herniation in the cornal reformates. And in my routine practice, I like to look at the bone window to look for fractures. With this thickened amount of extraaxial collection and midline shift, it warrants an urgent intervention of the neurosurgery.
Great. I think that's fine. So I think you picked up all the points on that. So you said that there's a swirl sign. What does the swirl sign indicate?
I feel in the hematoma there is still ongoing bleeding in process.
Okay. And what type of extraaxial hemorrhage is this?
This is EDH, an extradural hematoma.
Okay, extradural hematoma. So, what is the common association of an extradural hematoma? How will you differentiate an extradural hematoma from a subdural hematoma?
I differentiate on the basis of shape. This is a biconvex, convex, or lenticular shape, and usually the SDH ones are the biconcave.
Okay, yeah,
shape,
leave the shape other than the shape.
And this is most commonly associated with fractures.
Yes.
And yeah.
And anything regarding the sutures?
Yeah, so SDH usually crosses sutures, and no.
So EDH doesn't cross, isn't it?
Yeah.
And what is the most common source of bleeding in the case of an extradural hemorrhage?
Middle meningeal.
Just in case you know. If you don't know, it's fine. So
I know middle meningeal artery.
Yeah, that's right. Okay, so you said that you will pick up the phone and call the clinician, and anything else that you'll be looking to do at that point of time?
Just look at the bone window.
Yes.
Yeah.
And
any amount of herniation.
Yeah, I think you said all that. Okay, fine. Yeah. 42-year-old male with acute abdominal pain. That's okay. Yeah. Now you can just scroll and start speaking when you're ready.
Okay, I'm just trying to have a general look through this, and I've been provided with a portovenous phase, axial cuts of abdomen and pelvis in a skeletally mature patient. Let's try to look from top. I do not have access to the lung window. The mediastinal window of the chest appears normal. Coming to abdomen, liver and the visualized hepatic veins appear normal. Spleen appears normal. Pancreas appears normal. Kidneys and adrenals appear normal. The gallbladder is normal. coming down. I can see a dilated vessel around this dilated bowel loop, which I need to go back and look again. Which is it?
I think you can ignore the vessel.
Yeah, I'm looking where it's in continuation with the duodenum. So the jejunum has not crossed the midline, and we can still see it on the right side. And then it goes into a twist along with twisting of the mesentery in that lobe with the vessels and mesentery. I'm trying to
Okay, so
ascertain.
what are you basically seeing that you think that you're seeing?
There's a volvulus there with midgut volvulus, and it's caused proximal obstruction of the small bowel. And
what is the level of the obstruction?
At jejunum.
Okay. You mean okay, fine. So what are the things that you'll be looking for in this image?
So the very first thing I would be looking for any evidence of bowel ischemia, which I cannot see. I can see there's evidence of obstruction and no collection and for the this is the where I feel is the transition point which has got into the twisting, and if at all there is any thrombus in the visualized vessels.
Okay, so one is ischemia, you said. The other one, what did you say? There's no collection. Fine. Anything else?
Due to ischemia or perforation leading to perforation peritonitis or pneumoperitoneum.
Okay, so those are the acute findings you'll try to rule out. So what are the things that are that we usually tend to see if we are trying to establish a case of volvulus?
For volvulus, I'll first like to see which gut is involved, what sort of bowel loops are there.
I'm just saying, with relating to this case, what are the things that you will be tending to highlight?
So, it's since it is a malrotation, I'll like to see which vessel is being involved in the volvulus. Usually, it is the superior mesenteric vessels, and then
so what is the normal orientation of the superior mesenteric vessels?
So vein is on the right side of the artery.
So how is it in this case?
I shall look again.
Yes.
So here comes the artery. It goes. The vein is behind now, and then it just swirls around the artery.
Yeah. So with regard to the artery, which side of the artery is the vein? When you're scrolling down.
It was posteriorly, and then it just scrolls around, swirls
just
around.
Scroll up a bit. Scroll up a bit. Scroll up. Scroll up. Up further up. Yeah. So now just pause here.
It's in left. It is left to the artery.
Okay. So that is
malrotation.
Yeah. So what will be your next steps of management?
I'll inform the referring physician urgently, and in a patient would need derotation and the surgical correction.
That's up to the surgeon to decide. So your first job will be to just inform the surgeon, isn't it? Yeah. Patient with difficulty in conceiving, 30 years old female, just press 2. Yeah.
I have been provided with hysterosalpingogram study of this female presenting with infertility. I can see cannula in the cervix, contrast flowing well into the uterus. The uterus outline appears normal with slight indentation on its in its superior aspect. It is not convex of that. However, I can see intraperitoneal spillage of contrast on both sides. There is no cornual block. There is no definite beading of it. So, and even inside the intrauterine cavity, I cannot see any adhesions or any filling defect. It's just the fundal aspect which appears indented.
Can you see inside the intrauterine? Like, look more carefully inside the
endometrium. Sorry.
Yeah, I'm just saying that. Are you sure that there is no filling defect or there are no adhesions?
At this image, I
just scroll through the images once, and then when you're ready, you can tell me.
Sorry. I did
no problems. No, take your time.
Looking at this, I am not seeing any evidence of intrauterine filling defects or adhesions.
Okay.
Yeah. So I like to
You like to
put my
what are
differential put my
okay?
differential
Tell me
of
what are your differentials? Tell me. Yes.
of submucosal fibroid, or this could be an arcuate shaped uterus. Further imaging is warranted.
Submucosal fibroid because of the anterior indentation. That's what you're saying.
Yeah.
Okay, I think you can ignore that. And the shape of the uterus is also normal.
Then there's no beading of it.
So you said that the bilateral spillage of contrast is normal. I agree with you. I just want you to take a more careful look at the cavity. What do you think about the cavity?
So in the lower aspect, if I have to see, there is a linear contrast on the lateral aspect,
Yeah.
and then there's a filling defect, and then I can see
Yeah.
contrast. So
Okay.
that could point towards a filling defect, and then
Yes. Okay.
I would be
So what
bothered
are your
about the
differentials if there is a filling defect?
just this could be the uterine synecdoche,
Hmm.
endometriosis, or Asherman, basically.
Yeah. Bilateral leg plane, past history of metastatic breast cancer, press 2.
Metastatic breast cancer. So I have been provided with technetium 99M bone scan of the entire body in anterior and posterior views. I'm just having a general look. I can very well visualize the kidney, so this is not a super scan. In the region of the sternum, bilateral ankle.
Yeah, continue.
So I can see an uptick in the region
Yes,
of
yes.
sternum, bilateral ankle region, and also in the posteriorly in the cranium, suggestive of more centralized uptake, and also in some of the ribs, suggestive of metastasis because of breast cancer. I'm still trying to look for any other uptakes. Yeah. So this implies metastasis in a setting of breast cancer.
Okay, so what are your differentials?
Um, had it been more of appendicular skeleton, then it would have been some metabolic or infective cause. But in the setting of breast cancer, I'll put
No,
metastasis.
I didn't get the last part. What did you say about that? If it had been more in the
Appendicular, more
okay,
peripheral.
Mani,
In the
you are talking about a super scan, right?
yeah,
Okay,
yeah,
so
but
if
this
this
is
had
not a
been, if
super.
this, yeah, exactly, because you can see the kidney. So we don't have to think about that. I'm
Yeah.
saying that you are saying that there's metastasis in the calvarium and ribs, which I completely agree with you. Is there any other update that you can see in this image?
In the posterior scan, I'm not able to delineate what
No,
phase of the bone scan.
don't see at the posterior scan. In the anterior scan.
So I can see uptick in bilateral sacrum and medial pelvis.
And
With that age, I can think of a Honda sign of an sacral insufficiency
okay,
fracture.
fine, yeah. So yeah, so you say that the patient has metastatic breast cancer or metastasis,
Mhm.
and there is various uptake. Anything else in the lower limbs?
Mm,
Okay, fine.
there
I
are
guess,
upticks.
yeah, tell me, tell me.
There are upticks in the bilateral tibia and knee joints, patella.
Okay,
Yeah.
so I think the patient underwent an X-ray. So just press on number 3 once. Yes, what do you think?
Oh, there are symmetrical periosteal reaction along or cortical thickening. Maybe I call
Okay,
that.
what do you think about it?
I was
I think.
thinking of even hypertrophic osteoarthropathy in a setting of cancer.
Will
Symmetrical.
that be bilateral?
Symmetrical.
Okay, anything else?
Mm,
It's a bit of a tough job, I know. But since you picked up the metastasis and all, so what do you think? Okay, something went wrong. Okay, fine.
mhm.
Yeah. So, is there any other differential that comes to your mind when you're seeing this kind of symmetrical uptake in the femora?
Had it been focal, then I would have pointed out again for the stress fractures, but or insufficiency fractures, but
Okay,
just
fine.
not able.
So I think you did really well. If you just give me the control. Okay, you just stop. Yeah, okay, fine. Yeah. So this case was. I will start with the feedback with this case. So this case was actually you did fine with the diagnosis regarding the breast cancer. What I wanted to show you was that the bilaterally symmetrical uptake that you were seeing on the femur, that is basically because of bisphosphonate induced femoral stress fracture. So you did pick up the metastases which were there in the bones, like the sternum and the ribs and all. The only extra thing in this case, which will probably give you some extra points if you can talk about it, is the symmetrical uptake within the femora, which is related to the stress fracture, because it is a very common association which comes in patients who are having breast cancer and who are taking regular chemotherapeutic agents and stuff. It can result in stress fractures, and what people tend to do is then they advise bisphosphonates for that. Okay, so that was the only extra thing related to this case. Other than that, you did well. Okay, so this so this case actually you did fine at the end. So I know this is a difficult case. I showed you this case because this was my first case in the Viva, in one of the tables. Okay, so you can imagine the situation I was in. So I was also doing the same thing like you are doing. I was just trying to see anything in the spillage, and also everything was fine. And ultimately it was indeed filling defects, so they are a bit hard to pick up unless you're doing HSGs on a regular basis. So there are some areas which you can see here, as you later pointed out, which are not filling up with contrast. So those are the ones which are pointing to the filling defects. And this patient indeed had Asherman syndrome, which ultimately you got to. So that was the only thing. I mean, you did fine. Only thing is that you probably needed some help in this case. Other than that, this was okay. Okay, then going back to I think this was your third case. This case was also okay. So yeah, there is a midgut volvulus. So with relation to this case, what I will suggest you is that when you're describing the image and you're scrolling down, I'll advise that you just pick up the finding, take your time. You just tell the examiner that you're scrolling craniocaudally or caudocranially, whatever you're comfortable with, and then just take your time and tell the examiner that once you're there, you just pause, you don't scroll anymore. Because I felt that what some examiners with them, the problem is that they don't like the candidate scrolling too much while they are answering the question. So you just scroll to the point of your interest, and you tell them that this is you think what is happening. Then you go through your list of usual complications or whatever. Like as you said, there is no pneumoperitoneum, there is no evidence of filling defect. And yeah, so in this case it was you could see that there is something going on in the midgut. So what tends to happen more often is that there is a small bowel obstruction, suppose, and you keep scrolling and you don't see any obvious cause. Then what the examiner tends to ask you is, what are the things that you would like to rule out in a case of small bowel obstruction, which obviously you know. So in that case, you have to tell him about the possibility of adhesion, herniation. Then you have to tell him that I will go through the hernial orifices, or if you see to look for any filling defects in the feeding vessels, etc. And what they usually tend to do is, it will be most likely it's going to be a hernia somewhere hidden there, is down below somewhere in the inguinal region or in the femoral region. And sometimes it's a bit tough to pick up. So what used to happen with me was that I used to keep on scrolling and try to find the cause. And sometimes what happens, even if you in that stressful situation, what tends to happen is that even if you think that there is a hernia, but you just have to stop at the exact point where the herniation is there, and just so the examiner will want to see it, and then when you show him, then you can proceed further. So that is one of the things. But in this case, that was obviously not the case. So this one is fine. And I think you did fine in this one regarding the possible complications and stuff. So there is nothing else much to add on this. Okay, so this was pretty good. I mean, yeah, you picked up all the findings. You told me about the mass effect. You told me this is an extraction hemorrhage that is associated with bone injury and everything. And yeah, the bone window is very important. So the examiner will wait for you till you talk to him about the bone window. And then once you tell him the bone window, he'll like, I didn't have the bone window in this case, but usually they will have a bone window ready for you. And then when they show you the bone window, they will again expect you to describe what are the things that you're seeing and any associated findings. And sometimes what happens, there may be an associated maxillary sinus injury, or maybe some pneumocephalus hidden somewhere, or if there is any evidence of uncal herniation or transforamen herniation, those kind of stuff. So those are the additional things, and you can always take the examiner's permission to see the other reformats. So you said that you look for uncal herniation in the coronal reformat, and if it is there in this case, so if you want, you can always have a look at that, and usually the examiner himself or herself will show you the necessary reformat. That's about this case. And I think this was your first case. So this was again good. We picked it up right away. Talked about lead pipe appearance and featureless appearance of the bowel. So what I will suggest is that, right, the cross-sectional imaging should be the next step. In ulcerative colitis, yeah, it is usually a pancolonic kind of a picture with the entire colon being involved, starting from the large bowel loops. What tends to happen if this is this patient did have sacroiliitis. So because the history itself tells you that the patient has inflammatory arthritis, so that is the presenting feature. So the bilateral sacroiliac joints are definitely involved. And you may go for an MRI scan or to look for additional features, and it is more commonly associated with toxic megacolon. So that is one thing you should point out, that you're looking for any evidence of toxic megacolon and the necessary measurements. And if the examiner asks you about Crohn's disease, then what they tend to look for is one thing that you told, is any kind of fistula, any kind of collections and stuff. And one more thing is very important in Crohn's is the activity of the disease. So if you're doing an MRI of the small bowel, a very important thing that we are trying to see is there any active evidence of Crohn's. So if you're like really into it, then you can tell them that you'll go for the diffusion images and you see that there is any diffusion restriction or not in the walls. And if there is a diffusion restriction and there is in the high B values and there is a corresponding dropout on the ADC map, that points that there is an active disease. So what happens is that the patient with Crohn's may be followed up for months and months, and everybody knows that the patient had Crohn's. Only thing they want to see is whether there's any active component or not, so that they're to again start the patient on the necessary immunotherapy. That's one of the things about Crohn's, but this was again ulcerative colitis and it's fine. So I'll give you time. So if you feel you want to ask me anything, you can do that right now.
I think that was all perfect. Thank you so much.
Yeah, no problem.
Please find the link for the future Radiology University courses below. Join our WhatsApp or Telegram group to stay updated about the release of new videos, Viva tips, and monthly free FRCR Viva sessions. Oh, and I almost forgot, find our free book about FRCR 2B tips in the link below.